Hello, everybody from the Nini Brothers. It's a pleasure for us being back again on this amazing educational platform. Today, we are focusing our attention on the surgical veneer grafting protocol, and specifically, we're going to explain to you the step by step utilization of our SVG kit produced together with Omnia.
Welcome back to Dental XP also from myself, and thanks to all the XP team for the video editing, and to the Salama brothers for having us here once again. Implant rehabilitation aesthetic area is a clinical challenge because patients expect not only implant osseointegration but also an aesthetically ideal result and a reduction in the treatment time. Today's goal is to explain you not only the thought process which brought us to develop the surgical veneers grafting protocol, but especially the end-to-end procedure and the dedicated surgical kit we developed together with Omnia.
And most of the information are available on Dental XP. Of course, you can download for free the PDF of the article, but also in our website page, which is www.stodianini.it. We do have a reserved area in where, by entering with the password, which is Dental XP, which is going to be Dental XP, you will have the opportunity to download several other things that you might find interesting. But let's start and enter in the discussion right now.
In anterior maxilla, the aesthetic outcome and its long-term aesthetic stability is of paramount importance. That is why we should consider all the options we have and what we should do before extracting a tooth. First of all, when it comes to implant aesthetic management, we need to have a better understanding of the biology of peri-implant tissues and the limitations of the implant treatment that can aid in obtaining more predictable aesthetic outcomes.
So in one word, we should know which options do we have and what should we do.
Yes, the high smile line of all these patients, also known as the critical interface, demands a carefully planned and executed approach to provide a patient with optimal and long-term stable prosthetic and soft tissue outcomes, Andrea.
Yes, and especially in these kind of patients, which they are coming with us, and they have an high aesthetic risk profile. More than the osseointegration, these patients are expecting an optimal aesthetic result from their rehabilitation, and if it's possible, more and more, they are always asking for a concomitant shortening of the treatment plan when, of course, it's possible. So today we're going to try to give you an overview of the thought process. So we're going to try to give you the rationale behind the SPG and why we think that is an important clinical error to have in our armamentarium to solve this kind of complicated patients.
The frequently cited consensus statements regarding timing of implant placement defines four categories: immediate implant placement type 1, early placement with soft tissue healing type 2, early placement with a partial bone healing type 3, and obviously the late placement type 4.
And as it is also been discussed in a recent systematic review by Chen and his group, they investigated the outcome of immediate and early placement of implants in the aesthetic area. And despite the great, let's say, heterogeneity of the studies included in this elite review, immediate implant placement seemed to provide better soft tissue aesthetic outcomes. And let's see why.
Obviously, the diagnostic phase is of utmost importance, with not only bone and soft tissue deficiency being addressed, but also skeletal growth, dental implant soft tissue parameters such as altered passive eruption and the morphology of the roots adjacent to the dentulous area.
So basically we are saying that the diagnostic phase should be done clinically but also with the CBCT in order to define first of all which kind of anatomic scenario we are in, then deciding when to place the implant, type 1, type 2 or type 3 or type 4 as in the Boozer consensus in the Amberle consensus conference, or also anatomic. When we talk about anatomic scenario, we should always think about the two articles from the Salama brothers, Team Atlanta, and Dennis Tarnow and Team New York regarding the socket classification. Here we have the three main sockets that we always have in front, and we have type 1, type 2 and type 3. Type 1 we will see and we will be discussing more in details later on is the so-called ideal scenario because we do have both the presence of the buccal plate, so the bone and the soft tissue. Type 3 is, let's say, the most complicated to treat, but also probably the easiest one to diagnose because we are missing both the bone and the soft tissue. Whether type 2 is the most tricky situation because we are missing the buccal plate, but we are not seeing it because the soft tissue is there. So, as Alessandro just mentioned and pointed out, diagnostic phase is really critical in order to be successful in this kind of restoration.
So the type 1 scenario could be defined as the ideal one, with the presence of the buccal plate and the soft tissue as well, but is it always so ideal?
Yes, this is a good question because when you go back in the literature and they discuss about ideal situation, they say they speak about like thick bone, thick buccal plate, which is more than 1 millimeter usually, but unluckily this case scenario is less than 10%, is around 10%. So most of the time we are dealing with type 1 scenario with a thin buccal plate, and so that is the reason why we need to address all these things before touching the patient, understanding the option and tailor specifically the treatment plan according to the patient situation.
And remember, immediate implant placement can be a successful procedure in terms of aesthetics, but it is technique sensitive and requires an experienced team.
And a dedicated armamentarium as well.
Obviously. It is also less traumatic to the patient as fewer surgical procedures are involved and patients tend to prefer this clinical approach regarding quality of life.
But we said type 1 scenario, all our effort should be oriented to preserve what we have. We should extract the tooth, trying to be as minimal invasive as possible and then placing the implant accordingly. But what is important? Diagnostic phase, which are the risk assessment evaluation that we need to understand. Buccal bone integrity, we already discussed about it. The thickness of the labial plate, ideal or not ideal situation. We said that we do have the buccal plate which is less than 1 millimeter thick 90% of the time. Defining type 1, type 2 or type 3 by the presence or the absence of the interproximal height of bone, and this is extremely important and related to the papilla presence or absence. Gingival morphotype, and we will be discussing about the gingival phenotype and the importance of it being is completely different for us to treat a thin biotype comparing to a thick gingival phenotype. We need to understand how to manage the gap, the jumping distance that always tends to form after the implant is placed. And of course, we are talking about immediate implant placement and loading, so what we need to achieve, primary goal in terms of surgical target is primary stability.
And when an implant is placed in anterior type 1 socket, there is always a gap, a jumping distance to manage. Literature tells us that bone remodeling always occurs in the first healing phases, altering the buccal lingual dimension. The question now is which modern clinical alternatives do we have in our clinical armamentarium to offer to our patients?
And we can say that right now we do have three main techniques that you can utilize, such as the dual zone protocol described by Team Atlanta and Team New York in 2014, the partial extraction therapy described by Maurice Salama and Howard Glackman, and the surgical veneer grafting. And probably the dual zone protocol was the first one, no? And
Yes, and the dual zone protocol has been probably the turning point on this topic, introducing a completely new way of thinking, but also evaluating the most important parameters, such as the buccal palatal contour change, the peri-implant soft tissue thickness, and the gingival tissue discoloration.
so before deciding which kind of these techniques to utilize, we should always think biologically, understanding the guidelines of this technique, understanding the objectives, and then deciding which one to choose, without forgetting the therapy objectives, that we do have primary objectives, and our primary objective in this kind of situation is always to achieve long-term aesthetic stability of both the hard and the soft tissue, but also we do have secondary treatment goals, let's say like this, which are related to the patient, right?
Yes, in clinical studies that evaluated the quality of life, immediate implant placement emerged as the preferred alternative because of shortened treatment time, immediate aesthetic improvement, reduction of morbidity, and fewer surgical interventions. This short-term high satisfaction appears to be maintained in studies with a longer follow-up. The result of immediate placement and an immediate loading seem promising and show how reliable this approach can be. The question now is it important to contextually place a bone graft, a connective tissue graft, or both in the gap?
That's an important question, and we should understand that we are doing this in order to enhance the aesthetic result of the restoration, not to increase the survival rates or the osseointegration of the implant. That should be the key for you to understand.
Yes, because we wanted to improve what? The pink aesthetic score and also the white aesthetic score.
Yes, we want to basically create the perfect adherence, a perfect blending between the pink aesthetic and the white aesthetics. Because remember that when we are talking about anterior aesthetic area management, implant aesthetic dentistry is all about the pink, which is optimizing the white tooth forms.
In dual zone article, the authors, Team New York, Team Atlanta, also stated that many factors can influence the final aesthetic outcome, including the periodontal phenotype, that might require an additional surgical intervention. Probably a combination of bone graft and connective tissue graft can help in overbidding the socket site and achieve a sustainable and predictable aesthetic outcome, especially in patients with a thin gingival phenotype, and this is the rationale behind the SVG approach. The goal is to limit the buccal contour change after the extraction and potentially enhance the thickness of the peri-implant soft tissues coronal to the implant abutment interface. So we can hide what?
The prosthetic components that are underneath the implant itself. And in order to do that, we should understand and we should define which are the guidelines for this technique. We should define also which are the parameters, which should be negotiable and not negotiable parameters, but also we should define, and this is what we did, we should define like a dedicated procedure, a standardized procedure that must be done, in our opinion, in order to be done as best as possible with a dedicated surgical kit that you're seeing here that we produced together with Omnia. You see, it's not a huge kit, it's really a simple kit with seven instruments, but which are giving you the opportunity to create like the perfect SVG protocol, especially in the most critical moments of the SVG, because surgical veneer grafting is made out of 5 key moments, and we're going to see with this next case report or this case series, we're going to show to you the 5 different moments and where in these moments the surgical kit will be of great help for you to perform this procedure.
Patient with an high smile line with a failing left central incisor due to a palatal fracture who complained about pain and mobility of number 9 and a diastema who wanted to preserve. Notice the gingival asymmetry between the left and the right side of the patient mouth.
So you're seeing the first thing that always must be done is a diagnostic approach that always should be a combination of clinical evaluation, so defining which kind of gingival biotype we are in, probing all the different aspects of the tooth that has to be extracted in order to understand where is the fracture. And here luckily we had a fracture in the palatal side, so we were able to be in a type 1 socket of following the Tarnow classification, and so we were able, if we wanted to approach this case with an immediate implant and loading procedure, then what we are missing here is not missing here, because you're seeing the CBCT on the right hand side of this slide. And why the CBCT is very important here, because we are talking about immediate implant in the aesthetic area, and you will know that 95% of the aesthetic failures in this field are given by a misplaced implant, or also a misplaced implant can be done because there was not like a proper CBCT evaluation before. Why is that, Alessandro?
Well, Andrea, as we know, post-extraction bundle bone resorption and consequent mucosal recession are the main concerns in the aesthetic area. Therefore, thorough evaluation of the site and a buccal palatal planning of the position of the fixture are vital. To determine the feasibility of immediate implant placement, evaluation of the sagittal root position is very, very important.
And of course, the CBCT analysis is extremely important, and it's a must when we are approaching this kind of cases. So not only clinical evaluation, but also radiographic evaluation through the CBCT analysis, because the sagittal root position is another important thing that we must establish. We have a great article from Joe Kahn and his group that define 4 different classes of sagittal root position, class 1, from class 1 to class 4, and depending on the position of the root comparing to the vestibular bone plate. So class 1 we have the tooth which is adjacent to the vestibular bone plate. Class 2 we have the tooth which is in the middle of the alveolar crest without any contact with vestibular or palatal cortical bone. Class 3 which is where the tooth is adjacent to the palatal bone plate, and class 4 in where the 2/3 of the tooth is engaging the vestibular bone plate. In this specific case, we are in front of a class 1 scenario, which represents the most favorable clinical situation, as it gives us the possibility or sufficient amount of palatal bone to achieve primary stability, which is requirement number 1 during immediate implant placement. And before to start with the surgical veneer grafting protocol, I already mentioned that we have 5 main moments, and the first moment is the extraction. And how should we do this extraction, Alessandro?
Yes, the extractions must be atraumatic and
without flap elevation,
absolutely, and maintaining the periosteal blood supply to the labial bone plate.
Because as we know, and as it is well described in this slide, and also in our previous surgical veneer grafting webinars, which is available on Dental XP, the socket, the post-extractic socket, has the blood supply mainly given by the periosteum, because the periodontal ligament is coming out with the tooth. Then the osteum, we said that in the buccal plate we have less than 1 millimeter, so there is a thin bone, and so we have not that much of endoosteum. So the periosteum is mandatory